All right. Well, thank you so much. Thank you so much for Dr. Mona for joining and still jumping on our calls. So,
Sorry about
yeah, that's okay. So I was just going to introduce myself to everyone on the call. I'm Jennifer Hellman. I'm a pediatric nurse practitioner at Mott Children's Hospital, and I work with the pediatric otolaryngology group there. And I'm also, as well, a member of our Michigan chapter, NAPNAP. And tonight I'm also with my friend and colleague, Allie, which I'll let her introduce herself as well, too.
Hi, thank you, Dr. Mona, again for joining us tonight. My name is Allison Grady, and I'm also a member of the Health Policy Committee. I'm a nurse practitioner in Wisconsin, so just one state over, we're the hand and not the mitten. I work in oncology there, and I also work for Camp One Step, which is a camp for kids with cancer and their families. And finally, I am an academic in academia as well, teaching at undergraduate nursing at University of Wisconsin-Milwaukee. So Jen and I are thrilled to have you and to be running the show tonight. So thank you.
Yeah. So just a bit more of an introduction for Dr. Mona. She's the Associate Dean of Public Health and C.S. Mott Endowed Professor of Public Health at Michigan State University College of Human Medicine. She is the founding director of the Pediatric Public Health Initiative, an innovative partnership of MSU and Hurley Children's Hospital in Flint, Michigan. She is reimagining how society can come together to eliminate infant poverty with a first-in-the-nation program, RX Kids. A pediatrician, scientist, activist, and author, Dr. Hina was named one of Time Magazine's 100 most influential people in the world and recognized as one of USA Today's Women of the Century for her role in uncovering the Flint water crisis and leading recovery efforts. She is the author of the widely acclaimed New York Times 100 Most Notable book, What the Eyes Don't See, a story of crisis, resistance, and hope in an American city. So we're very excited to have you tonight with us and to join us. So Allie and I wanted this to be a pretty informal kind of discussion. So we thought we'd just kind of go through and ask you some questions.
that would be awesome.
And kind of let the discussion, go with things. So first of all, could you please tell us a little bit more about RX Kids and how it was developed?
Yes. So once again, I'm so sorry I'm late. It's great to be here with all of you. I love every interaction I have with my NAPNAP friends. So you guys are awesome. So thank you for your partnership. So RX Kids is just pure joy, and we call RX Kids a prescription for health, hope, and opportunity. And I think probably like many of you who are clinicians who are seeing patients, I have wanted for a long time to prescribe away poverty. It is a pathogen, it is a toxin, it is a bad thing, right? That impacts the health of our patients in so many different ways. It is the root kind of cause of so many problems, be it at an individual level or at a population kind of public health level. And I think for a long time, I've just been like, I can't do anything about poverty. Like, what can I do about child poverty? Like, it's like, this is like big problem. Like, we can't fix that. And then I think as a community, we also kept hearing from, we have a lot of community advisories and parents that we work with and kids, and we just kept hearing again and again, despite all the good things that we have been doing in Flint, especially since the water crisis, we have done so much awesome, early child care centers, trauma-informed care, nutrition services, Medicaid expansion. The list goes on and on of all these good things that we've been able to put in place. We just keep hearing how hard it is for people to get by. And then in 2021, as you probably all know, it was COVID, right? It's terrible. But actually, we ended up doing some really good things for people during this time. And at a national level, we expanded the child tax credit, which dropped child poverty to the lowest level ever recorded. Millions of kids came out of poverty. And with that, food hardship decreased and housing insecurity decreased and mental health improved for parents, less stress, decreased rates of abuse and neglect. All these amazing things happened. And then that was not renewed at the federal level by one vote. And millions of kids went back into poverty. So after that happened, And for so long, we kept hearing like, oh, we can't do anything about child poverty. It's too hard. And then we did, like overnight we fixed child poverty, and then that went away. And so RX Kids was kind of inspired by this national thing that we did, to take care of each other. And we wanted to do something at a scale that hasn't been done before. Flint, Michigan is one of the poorest cities in the nation, the poorest city in Michigan, and actually it's one of the highest rates of child poverty in the country. There's a couple cities in Puerto Rico that are higher rates of child poverty for children, but in the continental U.S., Flint has the highest rate of child poverty rate, near 69%, and it's about 14% for the nation. And we didn't want to do like a small pilot. There's lots of pilots of like cash transfers in the country because we didn't want to pick winners and losers. We wanted to do something for everybody. And we wanted to do something, once again, at a scale that was bigger than that has ever been done, to keep this work in the public imagination, to inform policy. The end goal was always to inform policy. So I know how to take care of kids, but I don't really know how to give people cash. So I blind emailed a child poverty expert at a institution down the street, the University of Michigan. I'm like, hey, I want to give all the kids in Flint cash. And I'm like, do you want to work with me? And he's like, okay. So don't ever hesitate to reach out to people and they'll respond. So we started to do the numbers, and we're like, well, what would it look like to do a child allowance, like an expanded child tax credit kind of thing, like for all the kids in Flint? And it got expensive real big. So then we're like, well, what if we narrowed the ages, like what if it's just 0 to 5? Because we know those first early years are so critically important that really kind of lay the foundation for future health and opportunity. Also kind of expensive. So then we looked at the science and where is the evidence, and where are people poorest? And actually people are poorest in the perinatal window. So towards the end of pregnancy, moms come out of the workforce, they lose income. We don't have any paid leave in this country, the only country that doesn't have paid leave, only Western country. And then babies are expensive, they need stuff, right? And then that dip in poverty persists until the first year of life. So at childbirth is when families are the poorest in their entire life course. And then for those of you, like for all of you, like we all know, like how important that window of life is. Like in the first year of life, your brain doubles in size. Like that is such a critical window of life, and that's when families are poorest. So RX Kids is a maternal and infant cash prescription program for every pregnant person in the city of Flint and every baby. So it's $1,500 prenatally, and then it's $500 a month for the first 12 months. So that's kind of a long answer to like why, because we want to eliminate poverty. We were tired of shrugging our shoulders because we can do this, and then kind of a little bit of what the program is.
Sorry, I was having a hard time coming off mute. That was a lot. And I'll just say, personally, I teach population health and simulation, and our simulation scenario is with a little baby and who's 2 months of age with a mother in poverty, and it is amazing just how expensive and how much happens in those first years. It's nuts. Anyway, so you kind of touched on this, but I was hoping you could talk a little bit more about who is involved, like who's giving them, who gives the money, like where did that come from, those sorts of things.
Yeah, and there's this beautiful kind of policy connections here too. So this has not been done before, like at a large scale, because we needed to raise a lot of money, because it's universal. It's for everybody. There's no means testing. So the design is universal and unconditional. We have an article in the Lancet coming out in a couple weeks, which is a review of kind of child cash transfer programs globally. It features RX Kids. And in writing that paper, we came to learn that 70% of countries have some sort of child cash transfer program. So this is based on really, really extensive global and domestic evidence that when you give, especially young families cash, like it improves outcomes, throughout their life. But that evidence also shares that how you design a program also informs the uptake of it, the acceptability of it, how people feel about it, but also the outcomes. So we were very deliberate in designing something that was for everybody, universal. Everybody within the city of Flint who's pregnant or has a baby. And when something is universal, as recommended by UNICEF and kind of the global evidence, it shares a different message than any other program that we have out there, like in terms of social services, where you have to be below a certain income or to qualify. A lot of those programs really kind of convey shame or stigma. Like, you're not making it. You don't have your stuff together. And here's a program that you can sign up for, that you can fill out a bazillion forms on, blah, 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 and you may qualify and you may not qualify. So the universality conveys dignity. It conveys kind of this sense of, this is how we're supposed to care for each other. This is a hard time for everybody. We see you, we hear you, we know how hard it is. And there's a village standing alongside you. So that's a big, important part of the design, is the universality. It's this concept of targeted universalism. It's everybody in a poor community. It's not for poor people, it's for poor places. And when you target something at poor places, it also allows you to talk about kind of the historic and systemic inequities that make it hard, for example, for certain people in certain zip codes to grow up to be healthy. And it shifts the blame off what we often do in these kind of programs. We blame poor people. We blame the victims for their situations. So the universality is a big part of the design. And then the second big part is the unconditionality. We are not telling people what to spend their money on. When the evidence shows that when you trust families, they will do what is best for their family. That's what the expanded child tax credit, and that's kind of what child cash transfers are based, child allowances in other countries. And that unconditionality, that allows for trust to be rebuilt. That allows for agency and autonomy and empowerment and kind of freedom and choice. So those are also kind of really important values that are built into the program. So to build this program, we had to raise a lot of money. And it really kind of like turned a lot of foundations and government, like, this is not what they usually do. Like, they like to develop, they like to police people, and there's a lot of paternalism in our programs, that really kind of with racist and sexist roots, that this is what we think you should spend your money on, and this is how you should do this, and it's only for these kinds of people, and you have to work and you have to do this. So we got some money initially from the Mott Foundation, which is based in Flint. Actually a lot of money. They gave us $15 million. But it was a challenge grant. They're like, you have to go out and raise another $15 million to unlock this money. And we didn't want it to be fully funded by philanthropy, because we wanted to do something that we built in Flint, but that we would eventually be able to replicate and disseminate. We wanted to be able to, once again, inform policy. So we were able to leverage money from TANF. So I don't know how much folks know about TANF. We're going to do a quick TANF history. So TANF is the Temporary Assistance for Needy Families program. It is what happened to welfare in 1996 during Clinton. So it changed from AFDC to TANF, and it became flexible state block grants. So states are given millions of dollars. They have to add a little bit of money, and then they pretty much have the flexibility to spend that money how they want. It's supposed to go to temporary assistance for needy families, but by and large, TANF dollars are misspent by most states. In Michigan, before RX Kids, only 6% of TANF dollars was going to cash to families. By and large, these dollars have been used for budget fillers in most states. You may have heard about the Brett Favre scandal in Mississippi, where this money went to fund like a volleyball court. So lots of misuse of this money that does not go to cash. So we presented kind of a different vision to the state of Michigan, to the legislature, to the budget office, the governor's office, like, hey, like, cash assistance programs, they're being misused. They're not going to families. They're not science-based. They're not prevention-driven. They convey kind of this, shame and stigma. What if you helped us support something like RX Kids, which is science-based, which is prevention-focused, which is inclusive? And we were able to leverage a provision in TANF I'm getting really wonky here, called non-recurring short-term benefits, NRSTs. And I'll put a link in the chat. We have a policy playbook that we published. So NRSTs allows you to give money for 4 months during an acute episode of need. So what did I tell you guys was an acute episode of need when people are really like struggling? Anybody can answer, or I can answer soon. So childbirth, right? Like that is the poorest time in people's family is when they're having a child. So that was our kind of justification for using this like little known provision in TANF to pay for 4 months of cash. And that got blessed by the federal government, by ACF, the Administration for Children and Families, said you can use NRSTs from TANF for 4 months. So the state is paying for the first 4 months of cash prescriptions, the prenatal and first 3 infant cash prescriptions. That's how we were able to use TANF money. But TANF money can only be and use NRSTs waive work requirements. They don't qualify. They're not part of lifetime limits. But you can only use it for like low income people, but you can define what low income is, and we define low income as folks on Medicaid. So the state provided through a budget allocation as a TANF redirection money for Flint initially for those first 4 payments for folks on Medicaid. And then it becomes a universal program by sprinkling philanthropic dollars. And when you also have philanthropic dollars in any cash payment, it allows for the protection of other public benefits. This does not count as income for families, so they do not lose things like Medicaid and SNAP and WIC and childcare and housing and all those other important things. And philanthropy then also helps us fill in until 1 year of age. So that's how it's how we were able to fund this. We have lots of foundations, ARPA dollars, all kinds, health system dollars. We have managed care dollars in here, all kinds of folks. And like foundations and other folks are like, like this makes so much sense. Like, why do we keep band-aiding poverty and working on transportation security and housing insecurity and mental health and this and that? Why don't we just fix poverty? So there's been a lot of excitement with funders as well who want to be part of this. So kind of based on our success in the last budget, the governor of Michigan added $20 million more TANF dollars to expand this to other parts of Michigan. And that TANF part is the kind of policy angle to make it replicable. So we're talking to folks in Ohio, North Carolina, Indiana, Arkansas, who now see kind of this path. They have unspent TANF dollars often. This has been also very bipartisan supported. We're expanding to the Upper Peninsula of Michigan, the Eastern UP, and the state senator up there wrote an opinion piece as why he, as a kind of pro-life conservative Christian, supports this. So we know the tent is everybody should be supporting moms and babies, but people kind of have gravitated to this program because it's time limited. It ends at 12 months. It includes a prenatal piece. It's very science-based, very low bureaucracy for folks that like small government. It's very, very efficient, which I'll get to another part of your question. It's run by Michigan State University, where I'm at. I have a partner at University of Michigan who's this poverty expert. But the people that do all the hard work is an organization called Give Directly. So Give Directly is an international nonprofit that kind of just specializes in giving people cash. So folks enroll online. We have a mama-tested, mobile-friendly application. It takes about 10 minutes where folks are able to upload, verification of residency, but also pregnancy through like ultrasounds or after visit summaries or childbirth. And then 70% of families choose a direct deposit into a checking account. And then the other folks pick up a prepaid reloadable debit card. So it's a very light, lean program, very minimal bureaucracy, unlike many other things. So the program started in Flint in January. So we're almost at our 1 year mark, which is amazing. We started in January. We've prescribed almost $5 million in cash, which is amazing, to about 1,000 families. And we're already seeing pretty incredible outcomes as expected. We did a survey in the summer with 3 control populations, no evictions in our families this year, which is amazing, and evictions in other parts of the county and in previous years. Improved housing stability, improved food satisfaction, food security, improved maternal mental health, including postpartum depression decreased, improved maternal well-being, improved trust in government, improved trust in healthcare. We've also been able to access vital records data. Another number, which is pretty amazing, is that we have about near 100% uptake rate, which is pretty incredible. Everybody is in the program, like with very minimal kind of outreach. Like people vote with their feet. People, it's. I've spent my career trying to reach hard to reach people. Everybody's here, which is pretty amazing. And so we can really look at the population level kind of administrative data. So looking at birth certificate data, we have an increase in prenatal care, more adequate prenatal care. People are coming in earlier, more often, less smoking in the 3rd trimester, decrease in extreme prematurity and low birth weight, an increase in gestational diabetes and gestational hypertension, which is pretty neat because we were below the state average and now we are closer to the state average. So that's primarily a reflection of people getting to prenatal care and being diagnosed. So lots of really great outcomes so far. And we're looking forward to expanding the program to other parts of Michigan and other kind of parts of the nation. And I'm going to put some of those things I talked about in the chat.
Great. Thank you so much, Dr. Mona. That's really impressive with all the ways, creative ways, right, to work on getting funding and trying to find those dollars to help make things like that happen. And it's your results sound amazing so far, for sure. So that's really exciting. So I know a lot of us, everyone's from different areas of the country. So if kind of thinking about this program, how do you think the program could be implemented in other communities? And how do you think that programs like these can continue to be sustainable? And how do we make them sustainable?
That is a great question. So it's amazing that we've been able to tap into TANF dollars, which is kind of the sustainable federal funding stream, but I really want CMS dollars. Like I want healthcare dollars, and that's one of the reasons we called it RX Kids. Like we spend so much money on healthcare in this country. And it's once again, by and large, a sickness-based system. We don't spend money on prevention. So we have had some early conversations with CMS about like how that could happen. Medicaid is funding some of our research through a Medicaid administrative match, but we want to tap into to CMS dollars. We also, Vice President Harris actually put, if you remember during her campaign, she talked about the $6,000 newborn credit that came from our program because it's $6,000 for newborns. However, even before she put it in her platform, we've been having conversations with congressional leaders in a bipartisan way about what RX Kids nationally could look like. Could it be, it would only cost $26 billion a year to do it, which is actually like fairy dust amount of money. But also it's much less to do it in poor communities. So kind of like how RX Kids is like in this kind of targeted universalism way. So there is some legislation on how to do this in other places. That policy playbook that I put in there is kind of a playbook for replication for other communities. Like this is how you can go about getting TANF, and this is how you can go about, and we're absolutely supporting all these places that want to replicate, and it's exciting. Like we're having good amount of conversations with folks in Elkhart, Indiana. Like their community foundation is like taking the lead. I guess that's the RV capital of America. Like who knew? You knew, Jennifer knew. And so there's like a lot of foundations and philanthropy and interest in doing something like this. And we're like, yes. So it's, I think people are looking for kind of, and it's being run by, they have a coalition called like building strong brains, like this early childhood group, they're like, we've already done everything. Like, this is the last thing we haven't done, or like, we're looking for the next thing to do. So we're excited to support other communities, but that playbook is a good way to start when thinking about replication. But talk to folks, like, talk to, your policymakers, talk to, different folks that control purse strings, talk to your health plans in different places. Don't be okay with the status quo. I think that's the take home story. Like, we weren't okay with it, just like we weren't okay with poisoned water. We are not okay with our babies growing up in poverty. Like, if there's something we can do, like, here's a good solution.
It makes me want to I feel like I need to go to the barricades. And so I love your passion for this. I think it's really admirable and it's amazing. So thank you for that. The last question before we open it up, I think for other people who are here that would like to ask a question or be a more active part of the discussion, can you tell us a little bit more about like how you're measuring success? You've got a lot of people and stakeholders who are interested and would just love to hear like what makes for a successful program besides obviously like connecting people with funds that they need.
That's a really great question. So, we are academics, and although, like, once again, we don't have to do any research. Like, this is built on so much evidence, the child cash transfers. Like, I was actually born in the UK. And I totally didn't dawn on me till recently, like, Mom, when I was born, did you get money? She's like, yeah, we got the family allowance. Like, everybody got money. Of course we got money for when you were a baby and when you were growing up. I'm like, oh, okay. So like, this has been, happening for a long time in lots of places. So there's extensive evidence. And our Lancet article that's coming out next week, we also kind of shares that, reiterates that. But of course, we're doing more science to look at the impact. And the neat thing is that because it's universal and population level, we can really look at things which hasn't been done before, like at a population level. Like, how does this impact things like community violence? How does it impact voter participation and democracy and civic engagement and, community cohesion? Like, we can look at these bigger things that you can't often look at when you're just doing individual surveys. Obviously, looking at the maternal infant outcomes, maternal mortality, morbidity, and prematurity, and low birth rate, and breastfeeding, and WIC initiation. So all those things which we've already been able to peek at. And then, participation rate, satisfaction. So lots of different kind of metrics of success. But, the take home, the reason we're doing this is to eliminate poverty for moms and babies. And 65% of the moms that have signed up, their annual income is less than $10,000. And this program is $7,500. So like, for some folks, it's a 75% increase in their annual income. And anecdotally, like, what we've been hearing, the patients that, the stories are like, this is life changing. I can stay home a little longer with my baby. And earlier this year, I had a mom who went back, missed her newborn appointment with a preemie 5-pound baby. We called, why didn't you come in? At 4 days of age, mom had to go back to work. This is not unusual. But also the beauty of the money, like, we're not giving like, this choice and freedom here. So we also, one of the last patients I saw last week, she's like, this money is going to 100% to childcare. This money is allowing me to go back to work, otherwise I couldn't go back to work. Families are sharing, like, I went back to school, I can pay tuition now. I can do this, I can do that. But by and large, funds are going to baby expenses, number one, rent, food, transportation, utilities, which is also consistent with the larger evidence on what families use their money on. I think also, like, another measure of success is like keeping it going, and then being able to like expand it to other places. Having it like, be part of more policy. Like, it was just like surreal when it became like part of Vice President Harris's like platform, and like I saw commercials on TV with a mom holding a baby. Like, imagine $6,000 in your first year. I'm like, oh my God, this is mind blowing. Like, I've never been part of something that so quickly has informed the national conversation. So that was pretty amazing.
That is pretty amazing. That's it's astounding that the results that you have so far, for sure. Since we still have a little bit of time left, I'm sure some of us on here would like to have some comments or questions for Dr. Mona. You know, we've been given a lot of great information tonight.
We've tried to put a lot on our website, so folks can check out as much there as possible. And I think a lot of the messaging on the website and is very happy and celebratory and joyful. Our logo has a heart. We have these cute teddy bears that have hearts. Every baby is mailed onesies. Look how cute they are. This one says love. And this one says best baby ever. And it comes with a card from the governor of Michigan saying, like, we love you. We're so happy you're here. So, like, these deliberate attempts to also, like, rebuild trust and rebuild the contract. We had a party on Valentine's Day, love songs to mamas. So a lot of this work is science and health and, you know, eliminating poverty, but it's also a lot of it is narrative work, you know, how fundamentally, like how we view people and treat people, especially moms and babies.
Lots of community building. I love that.
Yeah.
Elizabeth, you had a comment or a question?
Yeah, hi. Thank you so much for this. I've been following your program since it started, and it's been amazing to see to learn about it and see the growth and then hear you talk about design and implementation. And the narrative building is huge. I am, like everyone else on the call, a pediatric nurse practitioner, and also now getting my PhD in prevention science at University of Oregon and teaching undergrads, and taught your program in a class on child development in the family context, talking about the importance of supporting families. And the students loved it. And one student asked me, why, like very wisely, like, it's an amazing program, we love it, but how can you make sure it's not being abused? Like, how have family, so it's a really hard thing to have to think about, but like, have you come across this, or are there safeguards in place to protect from like mothers being maybe like forced to have children or in that way and so I didn't have an answer for her, the student who asked that, and I was curious if you all have worked with that at all.
So Give Directly, who administers the program, is like top of class in terms of safeguarding mamas and fraud detection.
Yeah.
So you know, triangulating different data sets to make sure this is really a person and that this is the information they're submitting is valid. So in the beginning, we had ultrasounds submitted that came from a website called Baby Maybe, where you can make like a fake ultrasound. Like, who knew? So like they've been able to like do a really good job in that respect. And then also in terms of kind of, once again, like safeguarding the moms, you know, making sure some of the moms like choose to actually come in and pick up a debit card because they want something in their hands, you know?
Yeah.
Not having to. We were also worried that like, because everybody knew this was happening in Flint, that like rent would go up or like food prices would go up.
Yeah.
We met with our attorney general to talk about consumer protection. So,
Right.
but nothing, like we haven't had any of those like stories, you know? And I think that's, and you know, there's always going to be we're expecting stories, you know, but there hasn't been, or you know, that hasn't kind of come up, and I think partly because it's just such a short program. It's just really like 13, 14 months, you know, one pregnancy and then in infancy, and then, yeah, some people are probably going to use this for things we don't want them to use it for, the money, but that's not for us to decide, right?
Right.
So that you know, that kind of is completely, and if you look at the big literature, like by and large, these programs decrease, you know, alcohol use, and they decrease, like we have a decrease in third trimester smoking, but we didn't actually tell anybody to stop smoking. Like feeling less stress, right? And then like you can think of multiple pathways. Like they know what they need to do to be healthy. They just they have all these other, you know, obstacles in their way. So you know, it's a tough question, but like you know, we're fortunate to work with this kind of with our administrator who can who has like the benefits counseling and, you know, has the customer service and the ability
Right.
to address that if need be.
Yeah, that makes a lot of sense. I think the concern was not as much like the fraud, but the protection of like safeguarding the moms and like protection of mothers. And so that makes a lot of sense. And I think you're, you know, that's this trust, it's a trust in humanity, and we, you know, and that it can that grows and builds. So thank you. I will pass that along. I will pass that along to the student, and thank you so much for the amazing work that you're doing and sharing it with us all. Thank you.
Would love to bring it to Oregon.
Yes, let's do it.
We talked to some folks in Washington State. They have, so I think there's like in their legislature, they actually put a feasibility plan to look at the feasibility of RX Kids or something. So there's some conversations.
Cool. Thank you.
I have like a question / might be getting in the weeds, but this is like my first time hearing of this program, and so I'm fascinated by all of it, and my brain is going like it's truly incredible. I'm Jess. I live in Colorado, so would be curious if anyone's working on it here. But I think I was just kind of looking at the links you put into the chat. And I think in my brain, I'm thinking of, you know, for a state who's like working on this, which community, you know, how do they pick the community? And I was looking at that. It looks like you use like the economic hardship maternal well-being survey. And is that like a national survey? And is like that what, you know, would that be a good set of data to use when like trying to, you know, pick a community to start in for your state? Or
That's a great question. So Colorado is amazing. So you guys have expanded, did a state level expansion of the child tax credit. There's about 10 states now that have expanded the child tax credit on their own. And Colorado is one of those and has, I think, one of the most generous packages. So we kind of, we started in Flint because it was the poorest city in Michigan, and it's where I am and where like I work, and that's where we have these relationships. And then the other communities were really based on child poverty rates. So other poor communities where there's high rates of child poverty, but also where there was local champions, like where people wanted to bring this program, you know, that was a big part of it. It's still a public-private partnership, so we get say, yay, we got state, we all pediatric people, so we got state money, but we had to have other philanthropic money. So the city of Kalamazoo, which is on the west side of our state, so they have a lot of philanthropy there, and they work a lot closely together. So the day after the budget passed in the state, a big foundation in Kalamazoo, the Stryker Foundation, gave $5 million to make sure that Kalamazoo could do that. And like to date, they've already raised another like $10 million total. It's like amazing. So, so places where there's high need, where there's excitement, where there's ability to build that public-private partnership. But we didn't want to go to places that just had like foundations, because those places like already have resources. So the eastern part of the UP, like there's like no philanthropy, and there's high need, and there's rural poverty. We really wanted to go to a place that was geographically, racially, politically different than where we were, and that represent, and that's and rural poverty, like they don't, it's harder to be poor in a rural community. Like you don't have all this nonprofits and like the density and all these other things. So we've outside philanthropy, so like the Bezos Foundation and like all these random foundations are helping us support the Eastern UP because we really wanted to do it there, and it was really important. So there was a mix of factors that we kind of figured out where to go next. But by and large, it is driven by the child poverty rate.
that's awesome. Thank you so much. And I'm like so excited to read all your stuff, read your book. All of it. I'm very excited. Thank you so much for being with us tonight.
You bet. There was a story, NPR covered the story a couple days ago. I'm putting that in the chat too. And it was about the expansion to the UP. Yeah, so just share the buzz, talk about it, read about it, learn about it. Like happy to stay connected and to I've learned so much about cash and TANF and all these different things I never knew about.
This is Allie again. I'm wrangling a puppy, so I'm not going to be on camera. But, I'm curious, what you think, or if you think that, a change in, administration is going to affect your program and what that looks like going forward, or is so much of it more state-based that it may not, have as much impact?
That is a great question. So yeah, I mean, it is very much a state level thing now. ACF at the federal level did have to approve it, but that was already approved, so I don't think they can backtrack that. And once again, we also have seen a lot of conservative support because of the prenatal element. Mitt Romney had a child tax credit bill a few years ago that also had a prenatal element. JD Vance has also talked about expanding the child tax credit. So there has been bipartisan conversation about child tax credits. TANF is a hot topic, politically. So I don't know what's going to happen. I don't think it's going to impact it. I'm not sure. We just actually went through a process with the Brookings Institute on how to scale something like this nationally. And some of their seasoned kind of politicos think that this is something that actually could be quite viable in this next administration, because it's so time limited, because of how folks think about moms and they don't want moms. Some, the work requirements, aren't as important for new moms maybe. So, we think there might be a window. It's definitely not going to be as easy as it would have been during a Harris presidency, but we think there may be a window. But our focus is still now on states, and especially replicating or sharing to kind of politically diverse states. Michigan is pretty purple, but it'd be wonderful to do this next in a red state, so that when it does come time to do this at a national level, we can say, hey, look, it's in Arkansas, and it's in Michigan, and it's in Indiana, and it's in blah blah blah.
No, I appreciate that. Thank you. That's one of the first positive things I've heard that way. So I like that. So thank you.
I was in DC yesterday. I'm in DC again next week. Our constituency is kids, right? We work with whomever to get what kids need. And I've also found that in the more recent work with RX Kids, that it's really hard to attack babies. This is a program about babies. Babies can't lift themselves up their bootstraps, so there's a little more empathy for babies.
I have a question for you too.
Mhm.
Can you hear me okay?
Yeah.
Here, I'll turn on my video. I usually don't, but I will if it works. I don't know.
Yes.
Oh yeah, hey. I'm representing Colorado as well. I'm in Woodland Park, but thanks for the presentation. And I was wondering, so for your program, is it just the short term 4 months, or is there an extension?
Oh no! So our program is it's a prenatal, and it goes till 12 months of age. So,
okay, sorry, I missed that.
So it's $1,500 and anytime after mid-pregnancy. It's a one-time in pregnancy. For equity reasons, people come into pregnancy at different times. We want it to just be the same amount. So $1,500 in pregnancy, and then it's $500 a month for the first 12 months. So $6,000 during infancy. So $7,500 total. TANF is able to cover 4 months, and they cover the first 4 months. But for low income folks. And then philanthropy and other dollars cover the rest.
Okay. Do you have any post surveys? So once their child reaches 12-month mark, and then what have you gleaned from those surveys?
Well, January will be our 1-year birthday. So we haven't finished 12 months yet. So we're almost there. And then we will be doing surveys, but really we'll be looking at a lot of the kind of objective big data on health outcomes and that we can kind of garner from Medicaid claims and different things. We also
Yeah.
have some of our researchers that are interested in doing kind of biomarker work with different, like, stress hormones and different things. So we plan to follow these kids longitudinally.
That's great. Yeah, I kind of grew up in it was bad, and so I'm happy for this program. I'm gonna guess it's gonna decrease like inter-partner violence, because that was something that was in my household when I was younger, between me and my brother. So I think this will really help with that.
Yeah, I didn't mention this. We also think the biggest impact is going to be in the child welfare system. So the peak age of child welfare involvement is 0 to 1 because of neglect, which is by and large poverty. So we take kids away from their homes. There's investigations because families don't have the resources to care for their kids, and then we pay for foster care until they're 18. So wouldn't it be just smarter just to make sure families have the resources they need? So we have a colleague who has access to the child welfare data. So we're hoping to see kind of an impact there too. Or anecdotally, one of our first families, she had a substance use issue, lost custody of her 2 older kids, was pregnant, was part of the planning of ARC's kids, had her baby in January, was able to prove income from this program and got custody back of her older kids. And she's like, this program made my family whole again. So lots of beautiful stories.